shipped to a higher center with mechanical thrombectomy. So this is what they call as hub and spoke model or drip and ship model. This is being used. I don't think it is there in India. But from aspirin to IV thrombolysis to IV thrombolysis in ambulance to mechanical thrombectomy, this is how which we have come ahead. So the basic purpose of doing everything in acute ischemic stroke is to salvage as much as possible of the ischemic region to improve the outcomes, to save the brain, to improve the functional outcomes. So ischemic region, which is going to be infarcted if we don't do anything, has to be rescued. This is the basic target, and we all know about that. So in the last 5 years, a lot of things have happened. The IV thrombolysis time window started with 3 hours, which is very narrow because we don't get, at least in India, patients who come to us with acute stroke within 3 hours, and after that we have to do a lot of things like CT scan and other things also. The time window expanded from 3 hours to 4.5 hours after ECAS-2 trial. But was it sufficient or is it sufficient? Then we all know that time is brain. This is something which we have been talking about for the last 15 years, that every minute, if we don't restart the blood supply of the brain, we will be losing 2 million neurons. But the fact is, it is not a standard number which will happen in each and every brain. Every patient is different, every brain is different. The story of 2 million neurons is good when we have to communicate the message, but there are a number of patients who will not be losing 2 million of neurons every minute, possibly because of good collaterals due to different auto-regulation mechanisms and maybe other physiology going on. The loss of neurons will be lesser. So time is brain, but the point is it's a tissue clock. It's not a time clock, and the tissue clock works differently in each and every patient. So there will be a subset of patients who are beyond those 3 hours and 4.5 hours, but who are not losing neurons as fast as other patients. So how to diagnose them and what we can do for those patients? What is bridging therapy? Is there any benefit of thrombolizing all the patients who can be managed mechanical thrombectomy and the resources are available? Is there any benefit to them? Is there any harm to them? And what are the newer agents we all know about tenecteplase, and is there any benefit? So we started with 3 hours, 4.5 hours. We all know that there is no need to do any specific imaging if we are thrombolizing patients with mechanical thrombectomy within less than 6 hours, if we have vascular imaging available. And the concept of advanced imaging in mechanical thrombectomy within 24 hours has also come up. And now there is enough data to suggest that we can thrombolize a subset of patients, IV thrombolysis, in less than 9 hours if we have advanced imaging available to us. So the window which started for IV thrombolysis to 3 hours is up to 9 hours in a certain set of patients, and mechanical thrombectomy window, which was less than 6 hours from time of onset, is almost 24 hours now, both for anterior circulation, posterior circulation strokes in a certain subset of patients. So more and more patients can be benefited with recanalization therapies. This is from a very recent article which was published in from a Journal of American College of Cardiology. And this is the basic structure of stroke management which can be used in any hospital in the world. If it is less than 4.5 hours, use IV thrombolize each and every patient. And if indicated, the patient has to go for endovascular therapy. Beyond 4.5 hours, and if the patient is up to 6 hours, you can go with less than 4.5 hours, you start IV thrombolysis, and the patient can go for mechanical thrombectomy if indicated. Or if there is a large vessel occlusion, the patient is beyond 4.5 hours to 6 hours, the patient should go for mechanical thrombectomy immediately. However, if there is a LVO, large vessel occlusion, and patient has come to us beyond 6 hours, or is the wake-up the stroke not clear, the patient can go for advanced imaging like CT perfusion. And if there is a significant mismatch, then that patient, mismatch means there is a lot of penumbra available, then we can go for mechanical thrombectomy in these patients up to 24 hours. But for that, what we really need is a CT perfusion or a MR perfusion-based imaging. But even this ASL, arterial spin labeling images of MRI can also surface, which are available at many centers. Even in Bulandshahr, they have an MRI machine which is doing ASL. So these are the gross recommendations. This is the gross framework of save the penumbra because the time is brain. We have to save the tissue. What I was talking about is the concept of tissue clock. That is something which was not talked about earlier, but as I said, every patient is not different. Every patient is different. So a patient with an average collateral with an NIHSS of 15 hours after stroke will have this area of core, which at the time of recanalization increases, but still we are able to save some penumbra. However, same type of patient who is having good collaterals will not have such an increase in core, and his penumbra may be sufficient. And if this patient we are seeing 12 hours later and we have a lot of penumbra to save, why should we try to recanalize? Because we have to save the penumbra, and the point is how to diagnose this penumbra. However, there will be a set of patients who will have bad penumbra within the first 3 hours after onset or very early into the stroke also. So, as I said, every patient is having a different collateral mechanism and a different penumbra. So we should not put every patient into the basket of the time window only. If we have resources available, find the tissue which is rescuable and try to rescue it. This is the basic, simple concept of stroke में हमको IV thrombolysis या mechanical thrombectomy क्यों करना है. So these are the CT perfusion images of two different patients. What we can see is that this is mean transit time image, this is cerebral blood flow image, and these are the cerebral blood volume images. So these are colored maps which come on the screen, and they are automated softwares available which will tell you how much is the core, how much is the penumbra, and they will give you the values and these colored images. In this image, if we see this blue area is having a decreased mean transit time, that the flow is slow. They are having a decreased cerebral blood flow, and the cerebral blood volume is decreased in this area only. So this red is the core, this green is the penumbra, and this is, as you can see visibly, that it is more than 30% of the core, and this patient will be benefited by endovascular treatment or IV thrombolysis, recanalization therapy, even if he comes to us after 6 hours of onset. Similarly, this patient is also having a significant penumbra, the lower one in the right occipital area. And these are the patients in which we are able to do advanced imaging even beyond 6 hours. They can be benefited by IV thrombolysis or mechanical thrombectomy. CT perfusion takes 5 minutes extra or few minutes extra, and it's done at almost all the same machines which are doing CT angiography. The only thing is software is required. So, all the efforts were made to improve the pre-hospital systems, to improve the triage systems, to make stroke teams, stroke ICUs, pathways, early CT scans, availability of TPA. But probably we have excelled a lot in that, though not in India. But the tissue clock concept is that improve your imaging, start doing advanced imaging in those patients in which where it is indicated, have AI-based reporting. So we are having rapid softwares and other softwares which interpret the images within a few seconds, 30 seconds to a minute, and you need not have a radiologist, and they will give you a very clear picture. This is the code, this is the penumbra, and have good referral models for those patients in which you are having significant penumbra and you feel the patient can be benefited by endovascular treatments or IV thrombolysis. This is the journey of IV thrombolysis agents. The earlier trials were streptokinase, did more harm than benefit because of the ICH. Then came in 1995 or 96 after NIMS trial, LT-place in a dose of 0.9 mg/kg body weight, and has been used since then in almost every country of the world. Then a new agent, desmotilase, there are a lot of DDAS and other trials, DIAS-1 and DIAS-2 trials were there with desmotilase, which showed some benefit, but there wasn't any significant benefit in outcome. And then has come the tenecteplase, with the advantages of rapid administration, bolus doses only, and number of trials have been done in tenecteplase, which have compared it with alteplase also. So the benefit of tenecteplase is that it is having much higher affinity than alteplase and a longer half-life. So theoretically, it appeared that it should be better than alteplase. We are talking about the original tenecteplase with which all the trials were done. So this is the journey of tenecteplase. A number of trials were done. NOR-TEST trial was done, which showed it to be non-inferior to alteplase, and then it was used as a bridging therapy in patients who were going mechanical thrombectomy, and the data kept on accumulating in the last few years. So this is something which I had taken from a 2023 publication in Lancet Neurology, updates on thrombolysis in stroke. So in the same article, they have discussed about, they have given this forest plot of trials of tenecteplase versus alteplase and the outcomes and the risk also, in which they have compared tenecteplase versus alteplase in terms of symptomatic ICH. And what you can see is that the outcomes and the risks both favor tenecteplase a little in comparison to alteplase. So it has been approved in some guidelines within 3-hour window, can be used as a replacement for alteplase. A lot of centers have started using tenecteplase even in European countries, in US countries, and probably within a year or so it will be approved by most of the guidelines for 4.5 hours as well as for a bridging therapy in mechanical thrombectomy. So this is something which has definitely come up in IV thrombolysis field in the last few years. So it has been there for the last many years, but the data has come up which supports the use of tenecteplase. So what I was talking about, that IV thrombolysis beyond 4.5 hours of a stroke. Do we have any data to support the use of IV alteplase beyond 4.5 hours, or these patients should go for mechanical thrombectomy only? So there were 3 trials, Extend, ECAS, Extend, EPITHEC, in which they included patients who were beyond 4.5 hours or were wake-up stroke with evidence of salvageable brain tissue using advanced imaging like CT perfusion or MR perfusion only. They were given alteplase and the comparison was with placebo. Patients who were received alteplase had a little increase in symptomatic ICH, which was expected, but this increased risk does not offset the net benefit of thrombolysis. The benefit to risk ratio was larger in patients who met automated perfusion mismatch criteria. So this is a little interesting thing which I'll show, that this is the overall data of the patients who were thrombolized beyond 4.5 hours on the basis of CT perfusion imaging. There were 2 subsets of patients, one in which a rapid software was used to analyze the CT perfusion imaging, and another subset was there in which no software was used. It was the neurologist or the radiologist who were interpreting those imaging. This data shows that MRS scores of 0 and 1 were better in patients who received alteplase. However, the benefit was maximal or even more than the overall data in patients who were thrombolized using the automated software. So the use of AI is going to be there, and the results of that thing are also visible in front of us, because these images are immediately processed and the numbers are given, and based on that, the results were even better in patients who were thrombolized using automated software. But the point is, if we have a patient with a stroke beyond 4.5 hours, up to 9 hours, and we are able to do a CT perfusion, and there is a significant mismatch of, let's say, more than 30%, we should give them benefit of IV thrombolysis with alteplase, and we have enough data to support the use of alteplase in such patients. Minor strokes, we all see minor strokes, and we at times thrombolize these minor strokes also. The European Stroke Organization, in a very recent guideline, they recommended not doing IV thrombolysis for patients with acute minor non-disabling strokes of less than 4.5 hours duration. Though the use of alteplase was safe, but it does not show any clear clinical advantages. So if you have a patient with a stroke less than 4 NIHSS, no major vessel or large vessel occlusion. Probably we can manage with aspirin and clopidogrel only. A very recent trial was published with the patient data of almost 1,000 patients, in which they compared dual antiplatelets with IV thrombolysis in patients with minor stroke. They gave a loading dose of clopidogrel 300 milligram and aspirin 600 milligram, followed by clopidogrel 75 and 150 milligram for next 21 days, and compared it with patients who underwent IV thrombolysis. And the results were almost same. There was no benefit in giving altiplase in patients with minor stroke. The breathing therapy. So we have a patient who has come beyond 4.5 hours and we see that there is a large vessel occlusion. So why don't we go for direct mechanical thrombectomy immediately? Why to waste time or cost in giving IV thrombolysis to such patient? So a number of trials have been done and a meta-analysis has been published. We talk about it. The potential benefit of IV thrombolysis should not be withheld from patients who are directly admitted to a center with mechanical thrombectomy. Even if you have mechanical thrombectomy, go ahead and do IV thrombolysis and plan for mechanical thrombectomy in parallel. Though IV thrombolysis may not give much benefit, but still it is not harmful. There was a meta-analysis of 5 different trials involving almost 2,300 patients. The treatment effect was 1 in 3 for mechanical thrombectomy, and the added benefit of IVT with mechanical thrombectomy in these patients was only 1 in 57. Very minuscule, it was around 1.7% in terms of numbers, and all these patients were those who underwent mechanical thrombectomy. Half of these were given IVT also, but still the verdict is you should not withhold IV thrombolysis even if you have all the resources available for mechanical thrombectomy. What we should not forget is that every 1 hour delay in endovascular treatment can lead to a 6% reduction in functional outcome. So many a times we are not able to do mechanical thrombectomy as early as we want to do, and in that case we should not withhold IV thrombolysis at all. So this is the meta-analysis we are talking about, and in which the patients who underwent IVT plus endovascular therapy did a little better in comparison to patients who underwent endovascular treatment alone, and there wasn't any harm in IVT plus EVT. Now, the dose of altiplase to be used in patients undergoing bridging is again debatable. You can use 0.6 milligram per kilogram body weight or 0.9 milligram per kilogram body weight as you feel comfortable. There is no verdict on that. This is something which is very new. It's not for IV thrombolysis. The major focus of the same thing is on endovascular thrombectomy. A recent trial, this is from China, which was published in NEJM, I think in February or January 2024 only. In this, they randomized patients with large strokes who are having large strokes visible on CT scan with large aspect, means very low aspect score, to endovascular therapy beyond 6 hours up to 24 hours. So we usually say the large cores will not benefit, but if the patient was having large vessel occlusion along with large core visible on a CT scan also, they underwent endovascular therapy. And what they found was that again, endovascular treatment was beneficial in patients in comparison to medical management. The MRS score 0, 1, and 2 were better in patients who underwent endovascular therapy. So a lot of data is going to come up in the next few years, which will tell us about how beneficial is doing mechanical thrombectomy in anterior circulation strokes up to 24 hours. And based on normal CT scan, and of course, if there is a clear perfusion defect on advanced imaging, there is no doubt about doing mechanical thrombectomy in up to 24 hours of the patient. Posterior circulation strokes, we can thrombolize even up to 24 hours if there is no large stroke and you feel that there will be benefit, and even mechanical thrombectomy can be done up to 24 hours. A very recent article published in Green Neurology a week back, in which they have analyzed a single center data of almost last 20 years, in which they have that cohort has both patients of IV thrombolysis and mechanical thrombolysis, and in which they say that almost 40 to 50% of patients with basilar artery occlusions or posterior circulation strokes can have good MRS of 0 to 2 if they receive IV thrombolysis, even up to 24 hours, depending on certain selection criteria. So this is an image which shows that this patient is having a dense MC sign. On a CT scan, there is an aspect score of say around 9 with a very small area of hypodensity. CT angio shows a complete occlusion of the right MCA. There is a large penumbra which is visible here as green color, and this patient was thrombolized. And what we can see is a complete recanalization of the right MCA, and the same area of CT scan hypodensity is left as a residual diffusion weighted image, and rest all this green area could be rescued because it was on penumbra and there was hardly any core at that time. So with this message that all the strokes are different, a different challenge, and we have to keep ourselves updated about what all we can do. The take-home message is IV thrombolysis with alteplase is safe. Alteplase can be an alternative. Late thrombolysis up to 9 hours can be considered with advanced imaging in selected patients, and mechanical thrombectomy is effective at times up to 24 hours, though availability is a limitation.
Thank you, Dr. Kapil, for a nice presentation and a detailed discussion for treatment of acute stroke. We'll be discussing all the questions later at the end when the both of the speakers present.
Yes.
Or any questions recently, maybe or all people are all the people are collected.
Definitely, sir. We will keep question answer session after talk of Dr. Rahul Gupta, sir.
Yes, that's
So,
fine. That's fine.
So, I request our second chairperson, Professor Avdesh sir, to please take over the session, and please introduce Dr. Rahul Gupta. Avdesh sir, please. Hello. Avdesh sir, please.
Yes. Thank you, Dr. Arvind.
Yes, sir.
It is an honor for me to join this session. And let me introduce Dr. Rahul. Dr. Rahul has more than 21-year experience in neurosurgery. He was trained at Government Medical College Rohtak and PGI Chandigarh. And he works as a teaching faculty member in the Department of Neurosurgery at PGI Chandigarh as well as in GP Hospital, New Delhi. Currently, he is working as a director in and head of neurosurgery department at Fortis Noida. He has presented many papers in national and international conferences, published many articles. He has done several fellowships, and his area of interest is endovascular neurosurgery and minimally invasive brain surgery and spine surgery. And he is going to talk about mechanical thrombectomy. Now I invite Dr. Rahul to deliver his presentation. Dr. Rahul, please.
Yeah, thank you, Dr. Avdesh. So I shall be sharing my slides. I think the slides are visible.
Yes, sir.
Yeah. So thank you, the UK Neurocon Society, which has given me an opportunity to speak on this topic. And I also thank Dr. Arvind for his efforts to unite this society, to unite everybody. And it's really thankless job, but he has done really great effort. Thank you, Dr. Kapil, for making my task easy. He has touched upon very important aspects of acute stroke. I shall be discussing some of them and mechanical thrombectomy. So basically, in India, still the stroke care is at a nascent stage. You can see that these are the various centers where the acute stroke program is run properly, where facilities for mechanical thrombectomy are present. So very few people are really getting advantage. Few patients are getting advantage of all the modern treatment of stroke which are available in the country now, though the developed countries have a more structured program. And in India also, a lot of it is company driven, as well as lots of people are taking interest in developing a stroke program in their institutes. Like in Meerut, Dr. Arun Sharma has done a lot of work, which is really commendable. And there are so many barriers in treating stroke patients, because in the pre-hospital we see that patients are being managed at centers which do not have any facility to diagnose stroke, and the important time, the useful time is being wasted. Also, the transfer to the higher center is not possible. And so the patients, though they may be in lakhs, but only a few thousand patients actually reach the patient center, which has the tertiary care facilities for acute stroke care, and they get benefit out of it. So when we talk about acute stroke, we are basically talking about hyperacute management of ischemic stroke, in which we want the functional outcome to improve immediately, safely, and effectively by restoration of the blood through the occluded brain, which can be achieved by thrombolysis, which is the intravenous medicines, or it is by the direct mechanical clot removal, which is done in a neurocath lab by various gadgets, which I shall be discussing. The possible functional independence up to the 70% of correctly selected patients can be achieved. So how to manage an ischemic stroke in acute setting? Basically, we have to discuss about the anterior circulation as well as posterior circulation separately. When we talk about anterior circulation, it is basically diagnosed on face or limb weakness with speech abnormality. When we talk about posterior circulation, it is diagnosed by vertigo, drowsiness, imbalance, vision abnormality, etc. Immediate action has to be taken, and patient has to be rushed to a stroke-sensitive hospital, which has the facility of CT scan, MRI, neurocath lab, availability of emergency team who know how to manage stroke, a neurologist, neurointerventionist, and other people. So I'll start with the representative case of a 35-year-old gentleman who had sudden right-sided weakness 5 hours ago with aphasia and right hemiplegia. Because the patient had come late, the intravenous TPA was not given at that time. CT scan did not show any hemorrhage. Shifted immediately to neurocath lab, and cerebral DSA was performed. So this was the cerebral DSA, which middle cerebral artery occlusion. On the AP view as well as on the lateral view, we can see how the cerebral perfusion is not present in one part of that is left part of the brain in the MC territory. So we immediately solitaire catheter. At that time it was available. It's about 7 years ago, which when it is disgraced, and we had passed the stent twice through that blocked artery. And this is the pictorial diagram of the solitaire stent, how it works. Through a balloon guide catheter, we have put this, and the clot has been retrieved. And you can see how the vessel has opened up. So we can see how the middle cerebral artery has opened up. On comparison in a lateral view, we can see how this has opened up. The area which was totally deficient of any blood the perfusion has occurred, and this was the patient who was pre-operatively quite drowsy. Then immediately post-procedure, he was quite sleepy, but he was able to lift his opposite side. And at the time of discharge, he was good. He was almost moving all 4 limbs. And at the end of 6 months, when he had come for follow-up, you can see he was in a very good shape, and he was almost everything was okay, except he had some mild aphasia. So that was the only problem which was left because of the infarct or the problem he had. He had reached the hospital after 5 hours of the onset of the stroke. So this is the stroke protocol which is being followed at most of the centers. The emergency medical system is geared up. They identify the stroke patient immediately from the signs and symptoms. Patient is immediately started with the IV fluids and taken to the CT scan room to rule out brain hemorrhage and try to diagnose the infarct by aspect scoring, as well as they can see a hypertense MCA sign if there is an anterior circulation stroke. And once that is found, then immediately the neurologist is called upon. The stroke neurologist comes, assesses the patient regarding his NIHS score. And once that is done, planning to do a thrombolysis is done based on his history, fitness for the IV thrombolysis, and IV thrombolysis started. Simultaneously, what we follow is we do a CT angiography or an MR angiography of this patient. However, if the patient has come late or there is some other problems, we can also go for an MR of the brain, but that usually takes time, and MRI may not be free at that time. But if it is free, we can quickly do an MRI 2-3 sequences. then MRI, MR angio or CT angio. If MRI is being done, then MRI angio is done simultaneously. Otherwise, we go for a CT angio. And if there is a large vessel occlusion, even if the thrombolysis has been started, we do not wait for the patient to improve. We directly alert the neurointerventionist, that is me, and the staff, and cath lab is opened and patient is shifted to the cath lab for an angiogram. There have been a few instances where the vessel has opened up and we have just done a DSA. So that is not like harming the patient. Even if the DSA is done and we see the artery has opened up, which was previously clogged, that is a good sign. But in 90% or 95% of the patients, in a large vessel occlusion, the vessel may not open up, and then you go for the procedure, that is the mechanical thrombectomy. So this is the protocol which is being followed at most centers and in our center. So why do you want to do a mechanical thrombectomy? Mechanical thrombectomy basically is a minimally invasive procedure, which is done in a neurocath lab preferably, but it can be done in a cardiac cath lab as well, in which we use mechanical tools to remove the clot which are causing a large vessel occlusion. And it involves navigation of catheter upwards from the large blood vessels in the thigh or wrist through the neck to the brain. So large vessel, I will discuss later. And it involves pulling back of the stent retriever or the aspiration catheter to dislodge or remove the clot which is obstructing that vessel. So it is needed for patients who are not fit for IV TPA, who have arrived after the window period, who have arrived within the window period but are not responding to IV TPA, or who have not responded to that. And there is a large vessel occlusion which usually doesn't open up with just IV thrombolysis. This can be done under sedation or general anesthesia. General anesthesia, if it is on the left side, patient is irritable and not responding properly, and it has to be a very quick procedure. So when we talk about large vessel occlusion, it includes internal carotid artery, middle cerebral artery, anterior cerebral artery, usually the A1 branch, basilar artery, and posterior cerebral artery, P1, P2, or up to P3. Middle cerebral artery, now up to M3 we are opening, but M1, M2 have to be opened. Patient should be within the window period. I will discuss about the window period. Serious medical contraindication for doing a DSA. When we talk about window period in IVTP, as discussed, it was initially 4.5 hours, but in some cases now with LTPLACE, we can go up to 9 hours. Mechanical thrombectomy, previously we were doing safely within 6 hours without any further perfusion scans, but now we can do up to 24 hours if there is a large penumbra. So that we can determine on doing the perfusion diffusion imaging on CT or MRI. And in posterior circulation, there is no specific data, but it has been seen that up to 24 hours, if the patient is not very bad, we can go for mechanical thrombectomy and open up the vessel, that is the basilar artery or the vertebral artery, or if required, it's the unilateral vertebral artery, or sometimes the PCA. But we have to hurry every passing minute because the viable tissue is diminishing and recanalization becomes less effective as the time passes. So we should not wait that patient has come in time, patient has reached in 90 minutes. We still have a window period of 4.5 hours. That is not true. We should not waste any time. So window period is important because brain is a very fragile organ. Blood vessels are very thin-walled and neurons are dying irreversible death because of the ischemia. Now, ischemia will lead to disruption of the brain barrier, and then the revascularization of the infected area will lead to brain hemorrhage or due to extravasation of the blood. And this will lead to hematoma formation. So it has been found that if there is a large salvageable brain in the initial phase, then it can be saved. Penumbra is the keyword which is for all types of acute stroke. In cases we are doing IV or mechanical thrombectomy, because penumbra is the salvageable brain where the blood supply is deficient, not totally cut off. This area can be saved by reperfusion, and it is important to open the blocked vessel by medicine or by removing the clot to save this penumbra. And CT or MRI based brain perfusion and diffusion imaging can tell us the size of penumbra. So we can determine the cerebral perfusion, we can see the cerebral vascular volume, we can see the MTT, and we can determine the penumbra. So if penumbra exists beyond 6 hours, then the patient is still a candidate for opening up the vessels by mechanical thrombectomy up to 24 hours. So this is a tissue of brain which is functionally impaired but structurally intact, and we can open it. We can make it functionally good also. And salvaging this tissue by restoring its flow to non-ischemic levels is the aim of reperfusion therapy. On the contrary, ischemic core is that area which is irreversibly damaged, which cannot be treated. And in this case, if there is if you open up the vessel, then there is an increased risk of symptomatic hemorrhage or malignant cerebral edema. So this is a similar slide was shown by Dr. Kapil. There is a small core in the red and there is a yellow penumbra. If we reperfuse, the penumbra remains the same, and that becomes that penumbra disappears, but the core remains the same, and it's a small area of damage, and the MRS is good. But if the penumbra is there and we do not reperfuse, then that penumbra will gradually become the ischemic core. It will be a large area of brain damage, and the MRS score may not be good. Now, mechanical thrombectomy and TPA are not mutually exclusive. So that is what was discussed by Dr. Kapil, and one of the papers had shown that when we are using both the methods, if the patient is coming within the window period with large vessel occlusion, and we know that it is not going to be opened by the IV thrombolysis, but still we give IV thrombolysis and shift the patient to cath lab so that we can have benefit of both the therapies. And when we talk about mechanical thrombectomy, we have two options. Previously, for last almost 10 years, we were doing stent-assisted clot retrieval here. The solitary stent by Medtronic was the first stent available. And now a lot of 6-7 stents with different designs are available. But now we are also got a thromboaspiration catheter, which again I will be discussing. So these Dawn and Diffuse trials have increased our window period in cases of mechanical thrombectomy. And there are certain radiological inclusion criteria which have to be seen on CT scan, MRI, angio, and CT angio. So we can see on MR angio and CT angio what we can do. So these are some of the parameters which we discuss with our radiologists. We have to see that the ischemic core volume should be less than 70 ml. It is better than it is easy to open up the vessel and be free in mind that there will not be an hemorrhage. The mismatch ratio should be greater than 1 point in perfusion studies, and volume should be greater than 15. So the various radiological aspects which we discuss are in the case of acute stroke with our radiologist is what is the aspect score. So it should be between 6 to 8. Then we do the MRI diffusion aspects as well. And we see the status of the collaterals on CT angio. And we look for the core infarct volumes. And we see for the marked penumbra and mismatched perfusion. रोहन एक बार फोन देखना कौन फोन कर रहा है. So these are the various criteria, the radiological as well as the clinical criteria which we follow before we So these are the diffusion perfusion images which we see. This was shown by Dr. Kapil as well. Wake-up strokes are sometimes strokes where patient has come with stroke, but we do not know the exact time of stroke because the stroke was detected when the patient woke up. And these cases may not be fit for an IV RTPA, so mechanical thrombectomy is usually the preferred method of treatment. So I'll discuss some of my cases. This is another case. This is again, the case was done almost 9 years ago, 8 years ago, 2015. So this was a patient who was known to one dentist, and patient had come to us from Ghaziabad with the MRI in his hand. And there was a large area of stroke on diffusion weighted MRI image. When we took him directly to the neurocath lab. This was one of the initial cases where we discussed with the administration that the patient will not be charged anything and will just take to the cath lab. And when we did the DSA, you can see how the middle cerebral artery area is deficient of blood supply. The MCA is suddenly blocked. At that time, only the solitary stent was available, but as discussed with the neurologist, we had cannulated the middle cerebral artery and we gave IV actylase at that time it was present, and intra-arterial thrombolysis was done. And we could open it a little bit, but it did not open up. So we now took the solitary stent. So this is on the right side. You can see how the stent has been placed, and when we had placed the stent, we took the chute. We can see the block has been opened up and the vessel is filling. So this is with the stent inside. Then we removed the stent and the clot had dislodged and the vessel opened up, and this was the recrystallized vessel. The post-operative CT scan showed just mild edema, and the patient also improved significantly. So this is the comparison. We got a TICI 3 opening of the middle cerebral artery within 1 hour of arrival of this patient to the hospital. So this is the classification which is internationally acceptable, the TICI classification, which shows how much the vessel has been opened up. If it is not opened up, then it is 0. And if it is fully opened up, then it is 3. So what most interventionists they aim for is a 2B or a 3 TICI opening up of the revascularization of the vessel. And it has been seen that early revascularization is always associated with a good outcome. I discussed about intra-arterial thrombolysis. We can give the ectylase or alteplase intra-arterially as well at the time of mechanical thrombectomy if this drug has not been given intravenously before. So they have been found to be some benefit. So there have been a lot of studies on revascularization. Initially, it started with Mercy trial, then there was a Penumbra trial, then there was SIFT trial with the solitary stent, and they have found various degrees of success and complication rates in their patients. So the Mercy trial, this device is no longer being used. Penumbra system is this same system is not being used, but we have some different thing now. Solitary stent became very popular for almost 5-6 years. This was the only stent or stent design which was available. Many other companies also came up with these stents which helped in removing this clot. So there were so many trials which were conducted by the with the help of the solitaire stent, and it was found that it is quite superior, effective, and cost-effective as compared to only IV thrombolysis or not doing anything beyond IV thrombolysis. Then came the new device, which is now popular in India for almost 3 years. We have taken this concept from the cardiology people who have been doing thromboaspiration in coronary arteries. And this is a direct aspiration first pass technique, that is the ADAPT. And in this, there is a wide bore catheter, which is quite malleable, very soft, and it can go up to the distal vessels. In anterior circulation, it can the wide bore catheter can reach up to the M2, and now the newer narrow bore catheters are also available to remove the thrombus or the clot from up till M3. So they are very soft and they can be navigated very well. They can be used in posterior circulation also very safely. So another patient, 51-year-old male who had an ictus at 4:30 p.m., had a history of cardiac illness, was on dual antiplatelets, had cardiac angio 1 week ago, sudden hemiparesis at home, reached hospital by 7, admitted under neurology, MRI and CT angio was done. And you can see on the plain CT scan, there was no hemorrhage. But when we look carefully, there was a hypertense MCA sign, which we can see on a plain CT scan, as seen in this picture. So IV thrombolysis was started and simultaneously CT angio was performed, and where we can see how the middle cerebral artery is blocked as compared to the opposite side. So CT angio is a very good investigation to tell us about the blockage of the vessels, also about the collaterals. So in this case, the CT angio had shown the middle cerebral artery block. You can see how the comparison shows it. And the MRI was also simultaneously done. Patient was given IV thrombolysis, and this showed infarcted area. So perfusion diffusion images were also done at that time, which showed a good penumbra. And so patient was taken to the neurocath lab under local anesthesia. And in this case, we took the thromboaspiration catheter. You can see in the red circle on the left side that we can see the tip of the thromboaspiration catheter. And through the thromboaspiration catheter, we had put the microcatheter. We could see that the middle cerebral artery is opening beyond that. And then that thrombus was sucked out. And in the first pass, we can see the vessel has opened up. On the right side, you can see the middle cerebral artery completely opened up. So this was the patient pre-procedure with hemiparesis. And after the procedure next day, he was moving both upper limbs. And on comparison, we can see how the middle cerebral artery has been opened up. So these are the results. This is how we can change the quality of life in these patients. And I showed some area of settled. And by the time he was being discharged, he was absolutely normal with mild facial paresis. Another patient of acute stroke. In this case is a little special because this patient had tandem lesions. What do we mean by tandem lesions? There can be lesions at 2 levels. So in anterior circulation, they can be at the level of intercarotid artery as well as middle cerebral artery. So a young 23-year female came with vascular heart disease, slept in the afternoon, woke up with deficits, was conscious with hemiplegia. So this was a CT brain which looked almost normal. IV thrombolysis was given. This was the infarct on MRI. And we can see the middle cerebral artery is not visible. And also, we were not sure whether the ICA is visible on CT angio. So CT angio, the ICA is also not visible properly. Rather, what we can see on CT angio, both the intercarotid artery are not visible. Whole of the circulation is filling from the posterior circulation. So you can see both the vertebral arteries, basilar artery, and then on the left side, you can see the middle cerebral artery, but on right side, the middle cerebral artery is deficient. So something wrong is going on. Nobody knows what is going on. We did a DSA. So perfusion showed a large penumbra. So we did a DSA. When we took a vertebral artery shoots, we can see that both posterior cerebral arteries were filling, basilar artery was filling, and left-sided middle cerebral artery was filling. So this was the right vertebral artery shoot. When we took the left CCA shoot, there was a sudden block of the initial part of the ICA. So that was a chronic obstruction to the ICA. That is why the circulation on the left side, the intercirculation on the left side was filling through the vertebral system. But on the right side, when we took the DSA shoot, the ICA was filling, but it was blocked in the petrous part. So we can see the ICA irregular, but it's blocked at the petrous part. So that means this was an acute thrombus or acute block at that time. So we took our devices in. First, we took the aspiration device. Gradually, we opened up the ICA block. Gradually, we reached up to the ophthalmic origin. Beyond that, PCOM artery we could see. And gradually, we could open the ICA completely, and ACA were now visible from the same side. So ICA opened up with the help of our aspiration device. And then we had taken now we could see the stump of middle cerebral artery block. So the delayed ICA should show the blocked MCA. So this was the initial yield which we had from the ICA. And then we took the microcatheter, microwire, aspiration catheter up to MCA. So now it is in the middle cerebral artery at the site of block. And when we opened it, the middle cerebral artery got opened, and you can see from the right ICA, the whole of the intercapsular artery is visible, as well as a normal MCA is also visible. So both the obstructions were opened up with the help of a aspiration device successfully in 2 or 3 passes. So this was our final yield. This is the patient on first post-procedure day. This on the third post-procedure day. And this is the fourth post-procedure day. So this is the smile on the face of the patient, which we always look forward to. We are eager, and this is what the outcome which we see sometimes. And like a surgeon, we enjoy it very much. Another patient, again, tandem lesion. He came with the MRI, sudden onset weakness 1 hour before IV TPA was given. We can see the middle cerebral artery did not show any flow in the territory. So in this case, on angio, so somehow this angio was initially not seen by me. And when I took the patient for the angiography, I could not palpate the right femoral artery. So I was surprised at what's going on. Patient with stroke and right femoral artery is not palpable. Somehow I could palpate the left femoral artery and cannulated the femoral artery. And when I took the shoots, we can see that both internal carotid arteries, the right one showed complete block, and also the left one showed complete block. But when I studied this carefully, we saw from the posterior circulation, again, like in the previous patient, the left-sided middle cerebral artery was filling from the vertebral system. But right side, we could see a cutoff at the level of the A1. So you can see at the level of A1, there is a cutoff. So this is the basilar artery. This is the PCA. There are the 2 PCAs. This is from the PCOM. The MCA is filling up. The anterior circulation ACA is also filling up through the PCOM. So the PCOM, the ICA is filling, then MCA as well as the A1, and opposite side A1 is also filling, but then there is no circulation on the opposite side, the right side. So there was something wrong which was going on. I took around 15 minutes to understand what is going on, and then I decided to go on the right side because the right side circulation had recently stopped. Left side, there was a chronic block, and the anterior circulation was filling from the vertebral system. But on the right side, there was an acute block. So I took shoots from the right ICA. I had put the aspiration catheter inside. Gradually, as I could take the aspiration catheter inside, I could see that there was a block at the petrous part. So at the petrous part, through the aspiration catheter, when I was putting the microcatheter or the microwire, it was not going any forwards. So that was the side. So there I had kept the aspiration catheter and sucked it twice. And also I had taken a shoot beyond that, which showed normal circulation after that in the ICA. So after opening up the ICA, then we looked for you can see how the ICA has been opened up. And we also used the stent along with the aspiration device, because after a certain limit, the aspiration device was not going any further and nothing was coming as a yield. So microcatheter was taken beyond that level. Stent was opened up, and with the help of aspiration catheter as well as the stent, we could remove these thrombus in 1 or 2 passes. And then we saw that ICA has got opened up, and now the stump of middle cerebral artery was visible. So this was a tandem lesion. One lesion was at the level of petrous segment and another at the level of M1 segment. So right ICA was identified. Long sheath was taken further in, and then we took the aspiration catheter, and through that we took the micro catheter. And when the micro catheter was had crossed the block, we could see the normal circulation at the MCA. And then after aspiration, the thrombus was again removed, and we can see how the middle cerebral artery also has been opened up. So the right ICA normal circulation was completely restored. So this was a yield, extracted thrombi at the end of the procedure. This was done in local anesthesia. Patient was conscious, and we could see that the vessel has been opened up very nicely. So another patient, a 41-year male who came with sudden right side limb weakness and facial weakness with slurred speech, inability to speak, altered behavior. He reached Escorts. This case was at Escorts. Within 1 hour, this was the MRI which showed stroke. The middle cerebral artery was not visible on CT angiography. IV thrombolysis had already been started. Then we took the patient for mechanical thrombectomy. We did the DSA. We saw the middle cerebral artery blocked, and we took immediately the stent and the aspiration catheter, and we removed this thrombus. And after removal of this thrombus, the normal blood flow was achieved in 2 passes. You can see how the middle cerebral artery has opened up. There was some hyperdensity and hypodensity minor infarct in the region of left MCA territory, especially at the level of perforators. And this is the patient who improved significantly, motor function improved. At the follow-up also, he came walking, and he was very happy about it, but he had some residual aphasia, which has improved significantly now. It has been more than 2 years now, and he's brother-in-law of one of our physicians. So he's good, and this is the photograph. So fully independent, doing his almost going back to work. He's an architect by occupation. And this was the MR angiography done at day 6 before discharge, which shows normal brain circulation on both sides. So coming to last case, I want to discuss this is a very important case, again, relative of one of our physicians, a 46-year male who had a cardiac bypass surgery at another hospital in Delhi. And he had another revision also. And now it was 8th post-op day after cardiac bypass revision. He was at home with the physician. At their home, patient had come from Chhattisgarh. There was no significant comorbidity, was on dual antiplatelet, but he developed sudden right hemiparesis and aphasia at 11 p.m. He was, the consultant had called me. It was a Janmashtami day. So I picked up the phone only at 12 midnight. By the time they had taken back the patient to Delhi in that center where the cardiac surgery was performed, which was approximately 30 kilometers or 25 kilometers from our hospital. CT brain was performed, CT surgeon was informed, but here we could see that there is no bleed in the brain, but patient has an hyperdense MCA sign. So this hyperdense MCA sign was seen, and immediately CT angio was performed on my insistence because the stroke neurologist was not available in the hospital on that night. He had gone somewhere. So the radiologist and the other team members were really reluctant on doing an angiography because they had not the facilities of the mechanical somatic, because the stroke neurologist was not there. That was the only interventions available in the hospital. So on my insistence and the insistence of the internal medicine doctor, my colleague, CT angio was done, which showed the middle cerebral artery to be blocked on one side. So since the stroke interventionist was on leave, IV thrombolysis was not possible. Patient was shifted immediately to Fortis Hospital, Noida by 1:45 a.m. And I also reached the hospital. Neurocath lab was all ready. Patient was taken immediately to neurocath lab, and on angiography, we could see that there is after the first perforator, first branch, the middle cerebral artery is not filling up on the left side. So this is what the towns and the lateral view showed. And then after this, we did a proper angiography, and we saw that some part of the middle cerebral artery got opened up. The thrombus must have been pushed. So now we took the microcatheter, we took the aspiration device. Through the microcatheter, we can see the distal circulation is filling. And with this, we also took the stent retriever. With the stent retriever, we can see partial opening of the vessel. The partial opening of the vessel was seen, but again, the distal circulation was not proper. And then we saw that the initial branch was not filling, which was filling normally, was not filling. And I could calculate that small branch also. We took a smaller stent there, and this was a yield which came out. And we can see how the complete circulation of the middle cerebral artery has opened up on the left side after using a stent retriever as well as the thromboaspiration device. Thromboaspiration device we could not take up to the M3 in the M2 in this case, and we had used a stent retriever also, and all the vessels were opened up. So this was the post-operative CT scan. Some extravasation of dye is usually visible, which can mimic a hematoma, but it is not hematoma because next day CT scan did not show any of that hyperdensity. So it was just a dye which had gradually weaned off. And 2 days later, there was some minor infarcts or hyperdensities. This was the patient pre-procedure. This was the patient just after procedure. This is after 4 or 5 days. And this is at the end of 6 months when he had come to meet me from Chhattisgarh. He's almost fine, going back to his work. Very mild aphasia he has. He misses out some words, but it is good to see the patients who had come in a very bad shape, and just by this procedure, which is quite easy to do nowadays with the gadgets available, patients can lead their normal life. Sometimes we do see complications with the endovascular procedures, not necessarily stroke, which can be contrast allergy, difficulty in access, vessel injury, vasospasm, reperfusion injury, fresh thrombosis, or even inability to reach or open. So what as a consent I take is that we can open up the vessel in almost 70% of the cases if the patient have come within time, up to 8 to 10 hours of the onset of stroke. But the clinical outcome may not be reciprocating the opening of the blood vessels. There have been a few patients in whom the vessel have been opened up within 6 to 8 hours, but the clinical response have not been very good, or some patients have even developed full-fledged infarct. So, but we should not wait for assessing whether there is a complete infarct or a partial infarct. If the patient is coming within the window, if the patient is very late, then we have to do all those perfusion studies. So the take-home message is stroke should be managed at hospitals with facilities of good CT scan machine and neurocath lab. Comprehensive stroke unit helps early therapeutic intervention. Patients with severe stroke who meet the criteria for IV TPA should be given this treatment. But patients should not be delayed for a mechanical thrombectomy if there is a large vessel occlusion. So we should not wait for half an hour or 1 hour for the IV TPA to act, but rather we should take the patient for mechanical thrombectomy if on CT angio or MR angio there is a large vessel occlusion. Patients beyond the therapeutic window with the large vessel occlusion can be a candidate for mechanical thrombectomy if the perfusion studies suggest a large penumbra. So medical emergency, acute stroke is a medical emergency, and we have to remember this. Be fast. It is very important, and all the people, even laymen, even relatives, even friends, even society, people in the society, they should be aware of these early signs of stroke so that they can reach a stroke hospital. For awareness, we do these type of activities at Fortis Hospital, Noida. So I thank you for your kind attention and patient listening. And this is the new neurocath lab which was installed about 2 years ago. Thank you very much.
Thank you, Dr. Rahul, for this wonderful presentation. You have covered almost everything in mechanical thrombectomy. And your last slide is very important, where you have said that this awareness is very important. We have such a huge population, but still we have very few centers here doing dedicated work. And stroke management is really a very dedicated work. Let us see if we have some questions. Any questions from the participants?
Session is open for question, please. If someone have any questions. I have one question to Dr. Kapil. So I want to ask about complication rate. If we increase the window period from 4.5 to 9 hours, what is the data till now? Rate of complication if we increase the window period from 4.5 hours to 9 hours. What data says? Dr. Kapil, please unmute yourself.
Meta-analysis which was published in 2022 or 2023, the benefits were more with IV thrombolysis up to 9 hours. So the benefits were outweighing the symptomatic ICH in these patients.
Okay.
So almost the same complication rate, about 1 to 2% of ICH, symptomatic ICH, which can be severe, if the patient selection is based on perfusion-based imaging.
Okay.
If the core is not large and you are having a large area of perfusion deficit, then the symptomatic ICH was not harmful, or it was not outweighed by the benefit which was there with IV thrombolysis.
So any other question? Thank you, Dr. Kapil. Thank you very much. Dr. Rohit, please, you can ask by yourself.
So Dr. Rohit has asked, can we do thrombolysis in patients with dual antiplatelets and warfarin? I think I am supposed to answer this question, Dr. Rahul. I'll try to answer that. So there are two issues to it. Let us talk about the warfarin first. If the patient is on warfarin, you can thrombolize the patient if you are able to get PT-INR levels and they are less than 1.7. Any PT-INR level above 1.7 is a contraindication. So recently, around 20 days back only, we had a patient. She was a 30-year-old lady, large VSD, reversal, Eisenmenger syndrome, came to us with a very large left MMC, in fact, within window period. She was not on anticoagulation. Our emergency people are so alert that they just took the sample and had sent it for PT-INR, and I had taken consent for IV thrombolysis, would have thrombolized the patient, but somehow the lab person came up with the report that, sir, iska PT-INR 2.0 aa gaya hai, and we abandoned the plan of IV thrombolysis immediately. So less than 1.57 warfarin is not a contraindication. Anything above 1.7, we cannot thrombolize the patient. Now, dual antiplatelets. Whether patient is on single antiplatelet or on dual antiplatelet, both of them are not contraindication for a stroke at all, IV thrombolysis in stroke. Of course, if the patient is on dual antiplatelet, the risk of symptomatic ICH increases, but there's enough data to support the use of IV thrombolysis in patients who are on dual antiplatelets also.
So, any other questions?
Yeah.
from the
Do you
house?
consider age also any factor for considering for IV thrombolysis?
So age, no bar. I'll give you one example. When I was doing my DM, Dr. M.V. Padma used to tell us, suppose Lal Krishna Advani is 82, fit, healthy, running gentleman. He comes to you with acute stroke. Will you not thrombolize him just because he's 80? So the rule is that, see, now the age is not a contraindication. Even the ECAS-3 data had enrolled a large number of patients who were above 80 years of age, and there was some benefit even in that population. So age is just a number, it's not a contraindication. Of course, the outcomes will be different. The complications can be a little higher, but still, I have thrombolized a 94-year-old gentleman who did very well and had come to me with acute stroke. So age is not a bar to consider IV thrombolysis.
My second question is for Dr. Rahul. Good evening, Dr. Rahul. Do you wait for the KFT report to come before getting the patient for mechanical thrombectomy, or you rush over the patient even before getting the KFT done?
No. We send all the samples, but we do not wait. If the patient requires mechanical thrombectomy immediately, so we will not wait for the KFT report to come. But by the time we have taken the patient, and it takes around 45 minutes from the emergency to cath lab and puncture and all this thing. Usually the report is available. Otherwise, we will use the less dye Visipack, and we can do it even with that. So the consent is taken that there can be a kidney problem in case the KFT report is deranged.
Thank you.
As per the expert opinion and the guidelines, there is no need to do any test except for a CT scan and a random blood sugar, whether you are doing IV thrombolysis or a mechanical thrombectomy. And the harm done by the CT, angio related dye or DSA related dye to kidneys can be reversed, will be transient, and can be handled with hemodialysis. But if you're delaying your things because of the KFT reports, it will do more harm to them.
Thank you.
So, is there any other question?
Dr. Rahul,
I'm Dr. Abhinav. A question for
Yes.
Dr. Rahul. What about the general GCS status of the patient while deciding before deciding for mechanical thrombectomy?
So, mechanical thrombectomy, we are not very much worried about the GCS status, because if you find other factors are safe and the patient vessel is blocked and patient is not decerebrating, then you can immediately go for it and open up the vessel. So basically, it's a very less invasive procedure. If we open up the vessel, circulation, but definitely you have to
Until how
rule out.
many hours you will wait for that? The highest limit of for this opening the vessel in anterior circulation stroke. Maybe if you see a large
So if
around
in case of large vessel occlusion in a patient of anterior circulation stroke, if the patient is coming beyond 6 hours, we will always do a perfusion study, preferably a CT perfusion, and we will ascertain the penumbra as well as the ischemic score. If the penumbra is more than 50% and the GCS is, though patient even if the patient is unconscious and there are no significant comorbidities like threat to the life due to other reasons, we will take up the patient for mechanical thrombectomy up to 24 hours if the large penumbra is there.
and whether the patient is having GCS of 6 or 7, that doesn't make a difference.
So that doesn't make a difference. In case the MRI, in that case, if the patient is having low GCS, we'll definitely do an MRI and CT scan both. So CT scan should not show any hemorrhage. MRI should not show any other major awkward finding, which may be suggesting the reason for a low GCS, which the patient may not improve even after mechanical thrombectomy. If only the infarct and the initial insult is the reason for a low GCS, we will go ahead with mechanical thrombectomy.
Okay,
Otherwise,
Dr.
the neurologist will decide, Dr. Kapil will decide whether we should go ahead. We'll need to discuss with the family and go ahead. Dr. Kapil, your opinion.
Doctor, I'll talk to Dr. Abhinav on the phone later.
Dr. Rahul, can you hear me?
Yeah.
Hello.
Please.
Hello.
Yeah, please. Yeah, Dr. Kapil.
Hello.
Yes, sir.
Dr. Akhil here.
Yes, sir.
Is there any absolute contraindication for your mechanical thrombectomy? What are the absolute contraindications?
For mechanical thrombectomy, sir?
I think the one. Yes, mechanical thrombectomy.
So even a deranged KFT, a patient on hemodialysis, it is not a contraindication for doing a mechanical thrombectomy. We have to talk to the nephrologist. Nephrologist will do dialyze the patient the very next day. So even if in many patients who are patients of CRF and they want an endovascular procedure or DSC to be done, the dye which we use can be safely removed by hemodialysis.
Okay, so now the dye is not a contraindication that you can use this dye.
So we are very careful. We use less amount of dye. There is another Visipack dye which is available, which has less iodine, so that can also be used.
Okay, so you have to take care of those.
We have to be very conservative with the amount of dye. No, sir. Absolute contraindication can be major coagulation disorder, some malignancy, which is terminal disease, in which mechanical thrombectomy may not be, or if there are large aneurysms or some other major vascular abnormality of the brain blood vessels, then we will not.
Can occur. Okay.
Yeah, so we will not go ahead with that.
Okay.
Another point is to Dr. Rohit's question previously. If the patient is on warfarin and you cannot do IV thrombolysis, you can go ahead and do mechanical thrombectomy in those patients.
Is there any other question, please? So I think I need comment from our chairpersons, Dr. Arun as well as Professor Avdesh.
I just want to ask a question to Rahul.
Yes, sir.
What percentage of our what cases we do not improve even after mechanical thrombectomy, even if the vessel gets opened? Do you have such experience, or what literature says?
Sir, the vessel has been opened, but the patient doesn't improve.
That's not shown clinical improvement up to the mark.
So we have had cases where we have opened up the vessel as quickly as possible within 8 hours of the onset of stroke, but the patient has developed ischemia or infarction in vital areas. Basal ganglia is involved, intercapsule is involved, and patient's GCS is not improving. So that has happened. Patient have had very slow improvement as well. So basically, basic idea is to open up the vessel, and whatever part of the brain which can survive, like which is penumbra, which is salvageable, that will be salvaged. But ischemic core, if it has involved a very vital area, then the patient may not improve as per your opening of the vessel. So that may happen. Similar is in posterior circulation. If by the time you are opening up the vessel, an important part of the midbrain or pons has been damaged, then patient may not improve significantly.
Definitely. I think it was a wonderful session, and everything about this acute management of stroke has been covered, both medically as well as surgery. In fact, endovascular therapy is also a form of surgery. What we can do is we can, I think we should make effort to do more and more cases, train more and more people, more neurologists, more neurosurgeons, more stroke units to be formed to get benefit, because this is a wonderful procedure. It can be easily done. Even if neurocath lab is not available, it can be in cardiac cath lab. Only thing that people should be encouraged. A lot of good devices has also come. Very quick. But definitely one thing requires their dedication and perseverance.
Yeah, it is very important, sir, because in the middle of the night, if the patient is there, you have to reach. The whole team has to reach immediately.
Yes.
You can't.
This is very important.
So that is a major challenge.
Yes. I think in our SGPGI, we have our emergency medicine has got, I will sanction the grant from ICMR for mobile stroke unit care, which has inbuilt CT scan and everything.
Dr. Arun wants to say something, but he's on mute. He doesn't realize that. Sir,
Arun sir,
mute.
please unmute yourself.
Unmute, sir, unmute.
Unmute yourself, please. Dr. Arun sir, unmute yourself.
I think somebody has to make a phone call to him.
Technical team, please unmute Dr. Arun sir. Technical team, please unmute everyone.
Sir, make a personal call, sir. Make a personal phone call to him.
Technical team.
Oh.
Yes.
Yes.
Unmuted. Yes. Arun sir, please.
Yes. Basically, today's scenario, we are talking of arterial stroke. We should think of venous stroke also. In arterial stroke, treatment depends on the gadgets available, the team available. Every neurophysician, neurosurgeon should be a good radiologist also, simultaneously. We should not wait for radiologists to comment. We should know everything. And other thing is, for venous part, I am just a patient with unconscious decerebration, with no sinuses visible. What to do? I have a few patients just now. We have done in 5 patients did sinus thrombectomy with the very good results. In a decerebrating patient, we just sinus thrombolized, aspirated. Next day, patient was fine. So we should not leave from the venous side also. It is also important. And as for the arterial is, basically we are treating the salvageable brain. We should treat a salvageable brain's numera at the earliest possible time, up to whatever time it is possible. Studies are reported even after 24 hours, thrombectomy can be done with the beautiful results. So we should not leave a numera at any cost. If numera is there, we should treat it. This is my personal experience. And every neurophysician, neurosurgeon should have a good idea of radiology. We should not wait for radiologists to come and report. Thank you.
I think it was a very nice and elaborative talk by Dr. Kapil Singhal and Dr. Rahul sir. I extend my sincere thanks to both of them to elucidate us about these nuances of acute stroke management. Dr. Kapil sir has given the very nice, elaborated very nicely about the recent updates in thrombolysis in stroke, and Dr. Rahul Gupta has elaborated about the mechanical part, thrombectomy part. So I extend my sincere thanks to both of them, and I request Professor Jaiswal sir to do the honor of both of them. Technical team, please show the certificates. Hello. Technical team, please show the certificate. So I request. Yes. So technical team, please. What happened? Please show the certificate. Hello. Yes. So there are always technical glitches in these Zoom platforms.
The
We-
problem is, la renon people are trying to share the screen, but they are not able to do it.
They're not able to do the things.
Ah.
So there are always the technical glitches in such programs. So,
Arvind, if it doesn't happen, it doesn't look like that we are not having Zoom meeting.
yes, sir.
It always happens, and it reminds us that we are working on a Zoom meeting.
Yes, sir. Definitely, sir. but still, I appreciate the Zoom platform that it has given opportunity to meet our to organize these meets.
Sure.
We are meeting every month.
Sure.
So that is bridging a gap between all of us. It makes the distances very short. We all are gathered at this at just a computer screen.
Definitely.
So this is the beauty of this Zoom platform. So is it possible to share, technical team, is it possible to share the certificates? Hello?
Yes, sir. Just.
Yes, please. What happened? Yes, so I request our chairpersons to do the honor of Dr. Kapil Singhal. He is giving very nice and elaborative talk about the thrombolysis. So, Professor Jaiswal, sir.
Dr. Kapil, please accept your certificate.
This is a virtual certificate. You will have the actual certificate during the annual conference, which is going to be organized under chairmanship of Jaiswal, sir. Avdesh is organizing chairman of upcoming conference. So you will get the physical certificate and everything during conference.
Thank you, Avdeshan, and it's my honor.
Please,
and I hope I'll be able to receive my certificate in person in Lucknow in coming days.
Sure.
Definitely. Technical team, please display another certificate. Hello. Yes, please display another certificate. Technical team.
Yes, sir. Just.
What happened? There's the technical problem. What happened? Hello. Hello. Is there some problem? Hello. Technical team, what happened?
Sir, another certificate is not opening my system. That's why it's not.
Chaliye, sir. I request Dr. Sharma sir to do the honor.
Dr. Rahul, please
Without certificate, we will
receive
hand
the
over certificate in physical
in
meet.
a forthcoming conference.
Sir, we will hand over
Congratulations.
your certificate.
Congratulations.
Thank you, sir.
Nice
Thank you for the gesture, sir. Nice gesture. Thank you.
Thank you, sir. Thank you for being with
Thank
us.
you, everyone, for being a part of this meeting.
Yes, sir.
Thank you.
Look forward to meet again and again.
I am also thankful to both our chairpersons, Dr. Arun Sharma sir and Professor Jaiswal sir, who has spared their time from busy schedule for this Zoom meeting. Thank you, sir. Thank you very much, sir.
Thank you.
Thank you.
Thank you,
Welcome.
sir. Thank you, sir. So this is I think we are at the end of this session. Thank you, Kapil sir, for being with us, and I am thankful for all our participants because this is success of this virtual meeting depends on the participants only. Thank you everyone for attending this session. Thank you very much, sir.
You are doing